All right, this presentation, we're just going to do a general strip review. So we'll start at the beginning with some sinus rhythms, move into atrial, junctional, ventricular, and then end with heart blocks. All right, so just looking at this rhythm here, first thing we want to look at is regularity. And the rhythm is regular. Next thing we're going to look at is our P waves. I have one P wave for every QRS complex. All my P waves are upright. They all look the same. My PR interval, I know it's hard to see the boxes here, but it doesn't look long or anything like that. It looks like a normal PR interval. So remember with the PR interval, we're measuring from the beginning of the P wave to the beginning of the QRS complex. So we'd be measuring from here to here. Looking at my QRS complex, so I have my QRS. I can see that it does look narrow, so that makes me believe that the rhythm is not coming from the ventricles. And my rate, which it's given me on the strip here, is 75. So that is within the normal rate of the SA node. So all in all, this rhythm so far is looking like a normal sinus rhythm. At 75 beats per minute. One thing that does make this rhythm look a little different is our T wave. So we can see here that our T wave is upside down, it's inverted. Whereas usually we would see our T wave be an upward stroke, ours is going to be an upside down stroke. And we do have some ST segment depression. So I marked over here my QRS. So my QRS complex ends here. We call that the J point. And that is below my isoelectric line. If I were to draw that imaginary line, kind of where my baseline is, it is below that. So I have some ST segment depression. And I also have inverted T waves. So being that this rhythm is regular, I have one P wave for every QRS. All my P waves are upright. They're all normal looking. They all look pretty much the same. My PR interval is normal. My QRS complex is narrow. And the only thing different is my T waves, that they're a little inverted, and I have some ST segment depression. So it leads me to believe it's a sinus rhythm at 75 beats per minute with that ST segment depression and inverted T waves. Right, looking at the next one, we can see our blocks a little more clearly here. First of all, let's look at my rate. So I'm going to measure from an R to R, and these are kind of hard to see because of, it being scanned in. So we'll just kind of guesstimate. See here, we can find a good one. So I have 5, 10, 15, 20, 22, 23. So let's take our 1500 divided by 23, that gives me 65. So I know that this is about 65 beats per minute. So that's a normal rate. Looking at regularity, is it regular or irregular? It looks very regular to me. So it does not appear to be an arrhythmia. I have a P wave for every QRS complex. All my P waves look the same. They're all upright. They're all uniform. And they have 1 to 1. And my PR interval looks to be within normal limits. Again, hard to see on the scanned and copy, but it looks to be about 4 blocks. So my PRI is normal. So everything about this rhythm is screaming sinus. One thing I notice about this rhythm is it looks like I have some ST segment elevation. So looking at my QRS ends there. So I marked where it began and I marked where it ended. And you can see where it ended, it is above that isoelectric line. Wow, that's a really bad line. So if I was to draw that line, my isoelectric line, you can see maybe over here where I didn't butcher it as bad. You can see where it begins and my J point where it ends. So I have some ST elevation. And that's predictive of a heart attack. So I have sinus rhythm at 65 beats per minute with ST segment elevation. We can just write STE for that. All right, just glancing at this rhythm right now, I can see that this rhythm is slow. So probably going to be a bradycardia, but let's figure out what our rate is anyways. First of all, is it regular or irregular? It looks pretty regular to me. I'm not gonna, we can just glance at that and it looks pretty regular. If you're gonna have something that's an arrhythmia, you'd be able to glance at it and see that it's not very regular. So let's figure out our rate. I have, this is a good starting point, 5, 10, 15, 20, 25, 30, 34 blocks in between my RR. So I'm gonna take 1500 divided by 34, and that gives me 44 beats per minute. So I do know that this is slow. I have a P wave for every QRS complex. My P wave is upright. They all look the same. My QRS looks narrow, so I don't have to worry about it being ventricular. And my PR interval is about 4 blocks, so that's within normal limits. My J point ends right on that isoelectric line, so I don't have any ST segment elevation or depression. So everything else about this rhythm is very normal, except for the fact that it is slow. So I'm going to call this a sinus bradyrhythm. Sinus bradycardia at 44 beats per minute. And there's nothing else really about this rhythm that's screaming anything, so we're just going to leave the title as that. All right, looking at this next one, I see those inverted T waves again. Right off the rip, I can tell these T waves are flipped upside down, so it's something I'll definitely want to note in my name. Let's go ahead and figure out our rate. First of all, it does look very regular, so off the bat, that's something we want to determine. Again, hard to see because it is scanned in. We have 5, 10, 15, about 19 blocks across. So I'm going to take 1500 divided by 19. That gives me a rate of 78.9, so we'll just call that 79 beats per minute. It's supposed to be a 7. My P waves, I have 1 P wave for every QRS complex. They are all upright, they all look the same, they all look normal. My PR interval, though it's hard to measure on this, but I can see that it's not that long, it's only 3 to 4 blocks, so it's within a normal PR measurement. And my QRS complex does look very narrow. Here, when I'm looking at the end point, so this would be the J point, the end of my QRS complex, it is slightly below that isoelectric line if I were to draw that isoelectric line. But it is so close that I'm not even going to worry about calling it ST depression. If it were to be ST depression, it would have to be at least, that J point would have to be at least 2 blocks below that isoelectric line. So if it's borderline or you're not sure, it's best just to leave it out, because if it's not deep enough that you're going to notice it, then we don't need to include it in the name. We do, however, want to include that these inverted T waves, these T waves are definitely upside down, whereas in a normal rhythm, we would see them be upright. So my rate is a normal between that 60 to 100, so it's not bradycardic, it's not tachycardic. It is sinus because my P waves are all normal. I have a normal PR interval. We have a narrow QRS complex, so it is sinus. So we'll call it a sinus rhythm at 79 beats per minute. You could even call it a normal sinus rhythm. I tend to leave the normal out if there's anything about the rhythm that makes it abnormal, and that's just me. So what makes this abnormal is that inverted T wave, so I would personally leave the normal out, but you can put it in there. But we want to make sure we note that inverted T wave. Inverted T waves are actually pretty rare. I just had a streak where I had a bunch right in a row, and these were actually all chest pain patients, which could indicate, the reason behind the inverted T wave, but there are a couple different causes of that. All right, next rhythm, we already have our rate here, which is already counted out for us, which is nice. This is irregular, so it would be difficult to count a rate on. What I would do for this rhythm is I would look at just a 6-second strip, which would be 30 small blocks across, and I would count how many QRSs I have in there, and I would just call it that. You can count a range, so you can take your longest interval and then your shortest interval, and you can count, a range, whether it be 60 to 100 beats per minute or something like that. But it does look irregular. So we can tell right off the bat that this isn't a regular, totally regular rhythm. This is actually a more difficult rhythm to see, and when we start to look at it, we'll see why. So when I first glanced at this, I thought this was Afib because it's irregular, I have narrow complexes, and the P waves aren't too noticeable. So I thought that this was an Afib rhythm. So this was actually really hard, and if you don't pick this up right away, don't feel bad, because it took me a while staring at this to kind of decide what it was. But then I noticed that I do have P waves, and I'm going to go ahead and circle my first sets of P waves. So when I look at all these P waves, they all look the same. They all look, uniform. So I'm like, you know what? This is a sinus rhythm. So what's going on with these other complexes? Well, there is a P wave here. It's hard to see because when the patient is moving, looks like they might have had a little tremor, and it's just a very small P wave. So if you notice, we form a pattern here. I have 2 reds, a blue, 2 reds, a blue. So there is a pattern to this rhythm, which means it's probably not Afib. My underlining rhythm is sinus. I have a P wave for my QRS complex. My QRS is very narrow. And if I were to add beats here, it would actually march out and be a normal rhythm. But I have these complexes that come early. So these are premature complexes here. So it just so happens that I was having a premature atrial complex happening every 3rd beat, and the P wave looks slightly different because it's coming from somewhere else in the atria. So those are actually PACs. So I would call this rhythm a sinus rhythm at 96 beats per minute with, you could say, trigeminal PACs. You could just write PACs, but it is every 3rd beat. So we have 1, 2, 3, 1, 2, 3. So technically you could call those trigeminal PACs, but just putting PACs is just fine. So sinus rhythm at 96 beats per minute with PACs. All right, looking at this one, we can tell right off the bat that it's fast. So probably looking at some kind of tachyarrhythmia. And I do have a heart rate here. It's 198 beats per minute. So I'm going to call this rhythm SVT. Now I have a couple different leads here, and we always want to look at lead 2 because that's where we learn what our ST segment should look like, what our P wave should look like, all those things. And I do have some ST segment depression here. So you can see that my QRS ends way down there. My J point is way low compared to where it started. So that's where my isoelectric line would be. So what makes this SVT over sinus tach or anything like that? Once we get over 150 beats per minute, our rhythm is going to be going too fast to be able to tell what is a T wave, what is a P wave. So a lot of people look at this and say, well, I have a P wave right there. But this is actually the T wave coming off the end of the QRS complex. And what's happening is that T wave is hiding what would be the P wave. So just looking at this, I can't tell if this is junctional. I can't tell if it's sinus. I can't tell if it's atrial because it's going too quickly. So we just kind of lump it into one big group and we call it supraventricular tachycardia, meaning it's a rhythm that's narrow because it's happening above the ventricles, supraventricular. But I can't necessarily tell, is it coming from the atria, is it coming from the SA node, is it coming from the AV node? We just know that it's supraventricular because it's narrow. Oops, sorry about that. Now the only one that does not lump into that would be Afib. Afib we can define as Afib with RVR, which would be rapid ventricular rate, so an Afib that's typically over 150 beats per minute, because the rate would be irregular, and we can tell that this is a very regular rate. So I do know that it's not Afib, but I can't tell exactly what it is because of how fast it's going. So we just call it SVT. And SVT is going to be any narrow, complex, regular rhythm over 150 beats per minute. So here we have another SVT. We can count the rate on this one. Let me find a good spot. I have 1, 2 plus 4, looks like 6 blocks. So 1,500 divided by 6 gives me a rate of 250 beats per minute. So very, very fast. It is narrow, so we can definitely see that this is a narrow complex here. So not like a VTAC. And it's going so fast, I can't tell if it's going to be atrial, junctional, or sinus, so we're going to call that SVT. Now I do have some ST depression here as well, so my QRS is actually going to end down here. You can kind of see that notch down here. So it's definitely below the isoelectric line. But again, it's going so fast. If you didn't pick up on the ST depression, it's not the end of the world. Definitely are probably a little bit hypoxic in the heart just because of how fast that rate is going. All right, now we're moving on into atrial. So I got my heart rate here, 54 beats per minute. So a little slow. Looking at this rhythm right away, I can tell that I have those sawtooth type atrial waves. So this is going to be a flutter. I have these flutter waves here. So we can see the different humps leading into that QRS complex. So now I need to decide, I know it's a flutter. It's going to be controlled because it's not a fast A flutter. We're a little less worried about controlled A flutters over uncontrolled because once it gets over that 100 beats per minute, we start worrying about cardiac output. Sorry about that. And now I just need to figure out my conduction ratio. So it can be a little hard to tell because some of these are not very clear. So I got 1, 2, 3, 4 flutter waves for that one. Here it almost looks like I have an extra 1, 2, 3, 4, 5 flutter waves for that one. Same here, I got 1, 2, 3, 4, 5, and I'm just counting the notches. Oops, sorry, my dog just bumped into me. I'm just counting the notches here. So I have a notch here, I've got a notch there, 3, 4, 5. So this conduction ratio does change a little bit. It's not a super consistent conduction ratio. So I'm going to label this as a variable conduction ratio. Now, say it was always 4 to 1, so I have 4 P waves per QRS complex. I would write that like this, 4 to 1 conduction. You don't have to write conduction, we just put 4 to 1 there. All right, got my heart rate up here, so it's pretty fast. Looking at this rhythm, I can tell that it is irregular, so it's something I definitely want to note right away. It's irregular. It is a narrow complex. You can see my QRS is only about a block, so it's only about 0.04 seconds. And I don't really see any defined P waves. Now, a lot of people will sit here and try to pick out P waves, but that could possibly be a T wave. So let's look at where there's a little bit of a break, because a lot of these complexes are very close together because the rhythm is so fast. So I'm looking where it slows down a little bit and I can actually see what's going on. I see those flutter waves. So the flutter waves, not very defined. They look like a squiggly line, and what's happening is the atria is fluttering. So if this was my heart and this was my SA node, what I have is these little signals firing off all over the atria. And that's what causes a flutter. And every once in a while, one of these little signals is going to get through and cause a conduction. And that's where I get my QRS complex from. And then I'm going to get a bunch more little signals, and the one will get through, causing conduction. So that's what causes a flutter, and this is how it's reflected on the ECG. Atrial fibrillation. So I'm going to write this as AFib at 165 beats per minute. Now this is definitely uncontrolled AFib. It's over 100 beats per minute. And we really like to see our AFibs to be under 100 beats per minute because I'm getting all different types of cardiac filling here. Between this one, it's only filling a little bit. Between these two beats, I have a little more time for blood filling in the ventricles, so I'm going to get a little bit more of a cardiac output with that beat. But then you can see with this beat, it's short again, so I'm not getting good cardiac output. So my cardiac output with each stroke is going to be a little bit different. And the slower the rhythm is, the more cardiac output we're going to get with each stroke than if the rhythm speeds up. So if the rhythm is over 100 beats per minute, we call that uncontrolled AFib. But if the rhythm gets to be over 150 beats per minute, we call that RVR. And that means rapid ventricular response. So we have AFib, it's over 150 beats per minute, and just like when I have an SVT that's really fast, I start to worry about my cardiac output dropping because the heart does not have enough time to fill between strokes to get a good cardiac output. So we could potentially see a loss in blood pressure there. So I'll call this AFib at 165 beats per minute with RVR, which means rapid ventricular response. All right, this is another AFib. So if we look at lead 2, which is right here, we won't pick apart this rhythm too much. We can see that we have our fib waves in between our QRS complexes. Our QRSs are narrow. Here's another good place where we can see our fib waves. And this heart rate was 150 beats per minute, which is an average because we know it's a little bit irregular. And we have narrow complexes. So this person was an AFib with RVR. Their blood pressure was pretty stable, but this was in the hospital in the ER, and we decided to cardiovert this patient. So they delivered an electricity shock, and you can see it delivers right on the R of the QRS complex, because that is when the ventriculars normally depolarize, and we want to depolarize at the same time that they would be depolarizing. We don't want to depolarize the ventricles while they're trying to recharge. So this was a planned shock to be delivered at a certain time. And it's kind of like turning your car off and on or your computer off and on when it's not working. It's going to reset. So again, we're looking at lead 2. So we do get a pause there, which is very nerve-wracking. Usually we do sedate our patients for these procedures so they don't feel it. But you can see when we come back, we go into a beautiful sinus beat here and here, and they went on to be in a normal sinus rhythm. We got a nice P wave, QRS complex, and a normal T wave. And then we even get a little bit of stronger beat where we got that nice P wave, QRS, and a T wave. So that's one way we can help fix AFib, and we typically only do the cardioversions if medications aren't working. All right, this is a 12 lead on a patient. So we're going to just look at lead 2, and the way that this 12 lead printed out, we do have a lead printout at the bottom of just lead 2. So I'm going to circle that so we can focus our attention there. So looking at this, I can tell that it's slow, and I know it's scanned in, so it's a little hard to see, but up here on the top of my printout, I have 34 beats per minute listed as my heart rate. Now looking at the rhythm itself, I definitely have what I call those flutter waves, the little sawtooth looking waves that form because the atria is firing off. It's irritated. So what's happening with this rhythm, this is our heart, our SA, our AV, and our conduction system goes down here. I have some spot in the atria that's just firing off at a normal pace. The atria likes to fire off 200 to 300 times per minute. So that's why we have so many flutter waves per QRS complex. So this is going to be firing off at 200 times a minute or whatever, how many it is. And then every 5th or 6th beat or so, it's going to send a conduction all the way through the conduction system. Which is a good thing because we don't want our heart trying to beat 200 to 300 times per minute. So I have my QRSs, they are narrow. And then I have my flutter waves in between. This does look pretty regular, so let's count out my conduction ratio. I have 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So this looks like a pretty normal conduction ratio. I have 6 flutter waves per QRS complex. So this rhythm is going to be a flutter at 34 beats per minute with a 6:1 conduction ratio. And this is controlled, even though it's very slow. It's very controlled, almost too controlled. But it's not uncontrolled because it's not going fast. What happened with this person is they had a dig toxicity. So they were on digoxin, which is a plant glycoside, helped to increase the cardiac contractility when you have heart failure. And this person was unable to take their digoxin for whatever reason. I can't remember if they were ill or what was going on with that. But their dig levels were completely off. And what happened is it caused them to go into this bradycardic rhythm. They probably had an underlying AFib or A-flutter to begin with because they had heart failure. But now that they don't have the digoxin to control how hard their heart is pumping, it can't work as well. So this person was very symptomatic. They were hypotensive, they were pale, cool, diaphoretic, and they eventually had to be paced. So we placed the transcutaneous pacing pads on this patient, and kind of works like a regular pacemaker in the heart, but we're going through the skin until they can get a pacemaker implanted. We also started a dopamine infusion on this patient, which helps with the contractility of the heart, and it'll also help raise the heart rate a little bit. So it's more, dopamine has more of a contractility effect, so it'll make the heart rate, the heart contract harder, but at the same time, it does help raise the heart rate. So that's what we did with that patient. Very, very sick. All right, so this is a reason you never trust what your monitor says. That is wrong. It is not a sinus rhythm. And we can see that it's not a sinus rhythm because our P waves are inverted. Now there was tape over this. There was like a piece of tape right here. So that's why these QRS are cut off, but they were as tall as the other QRS complexes. Our pulse is 63. And my P waves here are inverted. And inverted P waves are a telltale sign of a junctional rhythm. So looking at our heart again, we have our SA node up here, our AV node, which is going to go down into the bundled branches and the Purkinje fibers to get the conduction to go through the atria, the ventricles. So when I have a rhythm that's originating in the AV node, my signal is going to go this way to make the atria contract, and it's going to go this way, which is normal, down to the ventricles to make the ventricle contract. But since my signal for the top half of my heart is moving backwards, it's going to cause that backwards P wave or inverted P wave. Sometimes we won't see the P wave, so it could be a completely absent P wave because this is happening the same time the ventricles are contracting. So that P wave would be hidden in the QRS complex because the QRS complex creates a stronger deflection. So it's going to cover up that P wave. Or it could be that this is reaching the atria after the ventricles have contracted and we'll get the P wave happening after the QRS complex. And again, it'll be inverted. So we could have the inverted P wave before. We could have no P wave because it's buried in the QRS complex. Or we could have the P wave happening after the QRS complex, all depending on how fast that signal is traveling through the atria. But we know it's junctional, so we need to figure out what type of junctional rhythm it is. Everything else about this is normal. My J point is on that isoelectric line, so I don't have any ST segment elevation or depression. My junctional escape rhythm, which means my pacemaker has escaped to the AV junction, is between 40 and 60 beats per minute. If it is below 40 beats per minute, that's going to be a junctional bradycardia because it is bradycardic for that AV node. Accelerated junctional rhythm is going to be above 60 in less than 100. So it is accelerated for that pacemaker site because the normal intrinsic rate of the AV node is 40 to 60. However, it's not quite tachycardic, which we consider 100 and over. So this rhythm, being 63 beats per minute, does fit in that accelerated junctional category. Accelerated junctional rhythm at 63 beats per minute. All right, we got two strips here. We have this first one up here, and then you'll have one down here. So first, let's just look at this first one up here. Looking at my first complex, it looks pretty sinus. I got a P wave, a narrow QRS complex, a J point that's right on the isoelectric line, a normal T wave. Same with this complex, looks very normal. And then I got this guy, which we'll circle in a different color. When I look at this complex, I can see that there either is no P wave or maybe this is part of a P wave and it's inverted. But either way, it doesn't have a normal P wave. So I'm going to say that this is definitely a junctional complex. And it comes early. So I have beat, beat, and then this is premature because it's coming early in the rhythm. And then after that, I have two more normal sinus beats. You can see here. P wave, QRS, T wave looks very good. Now my rate is slow, so I'm at 38 beats per minute. So this is going to be a bradycardia either way. My underlying rhythm, which means the rhythm that's happening, besides this one irregular beat, I have a sinus brady rhythm here. It's slow. It's at 38 beats per minute, but I have a P wave for every QRS complex. My QRS is narrow. Everything about it is screaming sinus. So we have sinus brady. The one thing I have to add in here is this PJC with a PJC. And I know it's junctional because I either don't have a P wave here or there's a little dip down here that could be an inverted P wave that's just kind of pushed up against that T wave. But either way, whether it's inverted or absent, I know that that means it's junctional. So I got sinus brady at 38 beats per minute with a PJC. Now this next one is a little tricky. And it's a very rare rhythm that we would see. So when I look at this beat, I have a beat that's coming from the SA node. So I'm going to write SA. I know that because I have a P wave, a nice looking P wave, normal PR interval, and a QRS complex that's narrow and a normal T wave. When I look at this next beat, this is coming from the AV node, so it's junctional. My P wave here is inverted. It's still a narrow QRS complex. I still have a normal T wave. When I look at this beat, I don't have any P wave. So I know that it's junctional. Looking at this next one, I have the same thing. No P wave, so I know it's junctional. And then looking at the next three beats, they're coming from the SA node. Because I have a nice P wave, a QRS, a T wave, P, QRS, T. And they're all very regular. So what's happening with this part of the rhythm, this is the same patient. We have our SA node up here and our AV node here in the middle. For whatever reason, probably won't know, but some type of heart disease, this pacemaker is moving from here down to the AV node, and then it's going to move back up to the SA node. So it's wandering. It's moving down further to the AV node, and we can see that by the junctional rhythm kind of changing, where we have the upside down P wave and then no P wave. What's happening is that it's moving closer and closer to the AV node, and then it's going to move back here, back up to the SA node. So this is a wandering pacemaker. Very, very rare that we see that. And usually when we have a wandering pacemaker, it's jumping from that SA node down to the AV node back up to the SA node. And a lot of times we don't know why that happens. Usually it's idiopathic, meaning for really no reason at all. This person will probably have to have a pacemaker implanted in them. All right, our next one Our rate is 114 beats per minute, so pretty fast. Looking at my rhythm here, one thing I noticed right off the bat, my P waves are all inverted, so that's going to tell me right away that it's junctional. My QRSs are narrow and it's very regular. So now I need to figure out, is it junctional escape, is it junctional bradycardia, accelerated junctional, or junctional tachycardia? Being that it's over 100 beats per minute, it's going to be junctional tachycardia. Now everything else looks okay. My J point ends right here, which is right on the isoelectric line, so I don't have any ST segment deviation. It's just that it's junctional because I have those inverted P waves and it's pretty fast. All right, looking here, I don't have a rate on this one, so we'll have to calculate it out. 5, 10, 15, 20, 25, 20, plus 3 is 28, plus 1 is 29. So I have 29 little blocks. So I'm going to take 1500 divided by 29, which gives me 51.7. So we'll call that 52 beats per minute. My QRSs are narrow. My P waves are inverted. So we can see that the P wave is dipping down instead of the right way, which would be upright. So that's going to tell me that it's junctional. Now I need to figure out what type of junctional. Since it's 52, that's the normal intrinsic rate of the AV node, so this is just junctional escape. Now a lot of people want to label this one ST segment elevation, but it's not. My T waves are very tall and pointed. That doesn't mean that I have ST elevation. It doesn't mean that I have cardiac muscle damage. What this probably means is that I have a high potassium level. But when I look at this, my QRS ends right here. So I don't have, and that's right on the isoelectric line. So there's no ST segment elevation. I just have a very tall pointed T wave, which is commonly seen in electrolyte imbalances like high potassium. So that is not something that we need to put in the name. It's definitely something you want to note for your treatment. All right, we don't have any blocks on this one, so we can't count rate, but luckily it counts it for us. 57 beats per minute. Looking at this, my QRSs do look narrow. You shouldn't have to be able to always count blocks to see that they're narrow. Just take a glance at it, and if it's wide, you'll definitely be able to see that it's wide. But at this point, you should be able to glance at a QRS and tell if it's narrow or wide, and this one's pretty narrow. And I have no P waves at all. So again, makes me think junctional. Remember, junctional bradycardia is going to be below the normal intrinsic rate of the AV node, so that would be below 40 beats per minute. Accelerated junctional would be between that 60 and 100, so it is accelerated for that pacemaker site of the AV node, which is normally 40 to 60, but it's not quite tachycardic. And then tachycardia, junctional tachycardia, would be over 100. This falls right in the normal intrinsic rate of the AV node, which is what we had in our last one, so we'll just call it junctional escape. Nothing else to add here. Here's my J point. It's right on the isoelectric line. I don't have any ST segment deviation. Right, I threw this one in here because it's kind of a fun one. So right off the bat, we can tell we have a really big sinus arrest. We're not even going to label this one. We're just going to talk about it. So this was a patient in her 30s who had come in for a syncopal episode to the hospital. Passed out for no reason, just became lightheaded all of a sudden and passed out. So she came in, they did a 12 lead, looked pretty normal, and they put her on tele. And they noticed that she was having these big periods of sinus arrest. So we would call that a sinus arrest because it's more than one dropped beat. If it was just one dropped beat, so I maybe dropped one and then went back into a sinus rhythm, we would just call that a dropped beat or a sinus block. But since it's this long period, we call it a sinus arrest. That's probably the biggest sinus arrest I've ever seen. What I find interesting about this rhythm is that before we had our sinus arrest, we have a junctional complex. And the rest of the strip got cut off, but if you looked before this, you had a regular complex with a P wave, a QRS, and a T wave. So you had a sinus beat, and then you went into a junctional complex. And then when we come back, we have junctional, junctional, because there's no P waves. And then it starts going back into a sinus beat again. So what happens with this patient? She ended up getting a pacemaker implanted, so she doesn't have any sinus arrest again. But for whatever reason, and usually we don't know the reasons, she had a heart condition, that she's firing at her SA node, and all of a sudden the SA node is like, oh, I quit, I'm stopping, I'm going to take my union break. The AV node then senses that the SA node's not firing, and it's going to fire off. And then they go into a sinus arrest. The AV node senses that we're still not firing off, so it starts firing off again to try to stimulate that SA node, which then again began firing off again as she went into a sinus rhythm. So this is kind of like our fail-safe. This is why we have different pacemaker sites in our heart. If my SA node fails, my conduction system is going to move to the AV node. And then if the AV node fails, oops, sorry about that. And then if the AV node fails, let me get rid of this comments box. Then the ventricles are going to pick up and start conduction. So it is kind of our fail-safe mechanism. There we go. So just a very interesting rhythm for that patient. And she's pretty stable. She just felt like she was feeling a little lightheaded when she had that, and a little bit of chest pressure, but really that was it. All right, next one, we have our rate listed here, 72 beats per minute. Let's look at each complex. We can tell that the rate does change, but we have something more going on here than just an arrhythmia. So if you look here, I have a P wave, a QRS, and a T wave. Everything looks normal. My P wave's upright, my QRS is narrow, I got a normal T wave. Same here. You can see my P wave now here starting to change. It's smaller. My QRS is a little smaller, so the complex is starting to change. It is still sinus. It's coming from the atria, whatever. But now my pacemaker site is moving. It's moving from the SA node to here. I go into a junctional rhythm, into the AV node. You can see I continue to be junctional from here on out. So there's two different ways to label this. One way, you could be very specific, and you can say this is a sinus rhythm transitioning into a junctional rhythm. Or you can call this a wandering pacemaker, because our pacemaker site is moving from the SA node down to the AV node. All right, this one is kind of difficult to see because it's kind of small. We do have a heart rate up here, it's 90 beats per minute. We can see our QRSs, they look narrow. Just by looking at it, I know we can't see our blocks. And then here are my P waves. So that's kind of hard to pick out at first. So you notice that the P waves are inverted. But another thing that we can notice about this P waves, even though we can't measure out blocks, we can see that my PR interval is very long. Just looking at it, I can tell that it's over 5 blocks because it looks irregularly long. When we have a long PRI, we call it a first-degree heart block. Because for whatever reason, it's just taking the signal, which in this case is originating from the AV node, a longer time to transition down to the ventricles. So it's just taking longer for that. There's some kind of block here in the conduction system that's making that signal slow down before it gets to the ventricles. So my underlying rhythm here, because with a first degree heart block, we do have to label the underlying rhythm. It is junctional because I have those inverted P waves. It's 90 beats per minute, so it is not tachycardic, but it's not junctional escape because it's going too fast to be junctional escape. So it's accelerated. Spell that wrong. It's accelerated junctional at 90 beats per minute. with a first-degree heart block. And our first-degree heart blocks are the only ones where we need to name the underlying rhythm. And that's because it could be a junctional rhythm. It could be a sinus rhythm. It really just depends. So that's why it's important with the first degrees that we are going to label what type of rhythm that is. Oh, I don't know why it's jumping around so much. All right, we're going to go ahead and pause this, and then on the second portion, we'll cover our ventricular through our heart blocks.